Thank you. Good afternoon. I like teaching. I've never taught to college students before. I got to teach when I was assistant professor at the University of Kentucky, but I taught resident physicians, and I don't know, I was talking about things that they had a good background in, and so I kind of could get the lingo down at the right level. So if I'm going too fast or too confusing, please let me know, because I get carried away. I'm full of hot air. So I am a retina surgeon, eye doctor, which is what I do. It's my profession. But I also have got a fun hobby. I learned to fly a few years ago, and I've got a small plane. And I took my kids across the country with my wife to a meeting in Western Canada a few years ago, and it was one of the best things, most fun things I ever did. And I might throw a few pictures of that up here. But I will say that I do have some pictures that if it makes you queasy, you might just turn the other way, because some people don't like the medical things that I show up there. So, but I am going to be talking about anatomy, physiology, pharmacology, epidemiology, and that's kind of boring sometimes. It's important though. And I just might show some pictures up. I'll tell you this though, when you take your family across a trip across the country in a car, you can stop along the side of the road and let them out for their timeouts or whatever, but you have to get creative when they're misbehaving within the plane. So, but that's actually not my son. I want to do it to him sometimes, but no. I'm sorry? That's not my son anymore. That's not my son, no, not anymore, or ever was. But, well, quick anatomy. Most of the things that people think about of the eyes are the things that they can see on the outside, which are the conjunctiva, which is the clear skin that covers the white part of the eye, the sclera, which is the white part of the eye, the lids and the lashes, and these things that you touch and feel, they have a lot of pain fibers. They are the most common reason for people to go to the eye doctor, problems with these areas. But fortunately, they are usually associated with minor eye diseases, with allergies and conjunctivitis. The internal anatomy of the eye is where it gets a little bit more interesting. Well, it's all interesting, but this is where I deal with more of the part in the back of the eye. But you've got the cornea, which is the clear skin on the front of the eye. You've got the lens in the eye, which actually sits behind the iris back here, and the retina, which is what we're going to do a lot of it talking about today. These are the most common sites for serious eye diseases and that lead to more severe vision loss. There are other forms of external eye disease. This is a fellow who just was on the wrong side of a blow dart gun. But now see, this is where you can turn your backs. If you can handle this, you can handle everything else I'm going to do. But anyway, we're not going to be talking about trauma much. But that is another thing that I do is I fix, if you stick a fork in your eye, that's the kind of repair that I do. Corneal diseases. Everybody always, well, not everybody, but a lot of my patients ask me, well, they've got an eye that's going bad. Can we just transplant that eye with a new eye? And the answer is no. The eyes are very, as soon as they can figure out how to do brain transplants, maybe we can do eye transplants, because the retina is kind of an extension of your brain into the eye. And so we don't know how to do that yet. But we do transplant parts of the eye, and this is a picture of a corneal transplant in the middle of it. This is the skin that was donated by someone who passed away, and it's replacing this part of the eye on the host, or the patient who had the problem. This is used for fixing scars or other diseases that cause this skin to become cloudy. And it's the cornea is like the window into the eye. If your car windshield is broken or scarred or stained, it makes it hard to see. It makes it hard to drive. What's the retina? Well, the retina is where I'm more interested in, or what my job is more about. It's the lining of the eye. It's the neurons that take the light energy and transform that into a picture, which sends a message to the brain. And these pictures change instantly. I mean, you look from one thing to the next thing. You can imagine how fast the eye can adapt to light and give us that information that we use. Sometimes this is a different picture of the retina. Can anybody see, is there anything that might be wrong with this picture? Anybody? This is interactive. There's a splotch in it. Yeah, this is a dark maroon spot right here. That's a hemorrhage. That's a hemorrhage under the retina, and that's not supposed to be there. And that's one of the things that can show up inside of macular degeneration. Actually, I think this particular patient was getting a treatment at a chiropractor with one of those massage beds with a high pressure water massage, and just the pressure from that caused a little blood vessel to rupture, not in the white part of our eye, but back underneath the retina. So you can get them for different reasons. This is another test or another way of looking at the retina. We do something called fluorescein angiography, and this is where we give a patient a little dye in their veins, and it goes through their blood stream, and it gets underneath the blood vessels of the eye. And if you have certain pathology, it shows the pathology up a lot nicer, and it can give me an idea if this tissue is deep underneath the retina, on top of the retina, if the circulation is still going there, or if it's leaking. And in this case, after 10 minutes, which is this little number right here, this dye was leaking out of this area, and this is actually a form of wet macular degeneration where there was a growth under the retina, this growth of blood vessels, and it leaks the dye out, so that you develop fluid under the retina. There are other ways of looking at the retina. This is a histopathology slide of the retina, which is basically from a dead person or from a person who died. You could take a biopsy of the retina, but that's not usually a good idea. But so you've got the rods and the cones layer right here. Well, those are what we call the photoreceptors, and that's what takes the light energy and turns it into an electrical impulse. But if you'll notice that there's several layers within the retina, and all those layers are cells which support the rods and the cones, and then there's a really dark area underneath it, which is made up of tissue that actually feeds the rods and the cones, and that's important in macular degeneration. What we can do with a person who comes to the office is do what's called an OCT test, which is an optical coherence tomography test. And I actually had to refresh my mind what OCT means today because I just call it OCTs all the time. But basically that's a laser picture of the layers of the retina on a cross section. And we find this very useful because here's a picture of an abnormal one. This is a patient who's a fairly normal retina OCT, and this is an abnormal one. Can anybody guess where the abnormality is? It's this dark area down here where actually this is a collection of fluid under the retina. And there's probably either a blood vessel or a little lesion right there that's contributing to it. But this is the abnormality. And we look at tests like this, which we can do sometimes without even dilating a patient to find out if they've got active disease or not. Well, very quickly, retinal disease, there's three big diseases that we have. Number one is macular degeneration, which we're going to be talking about a lot today. Number two is diabetic retinopathy. And number three is retinavascular occlusions, which are like strokes to the eye. All three of these things can lead to severe loss of vision, and a lot of times it's permanent. Macular degeneration, finally getting to what we're here for. It's a progressive, chronic, age-related disease which causes damage to the retinal tissues, and it's a leading cause of legal blindness in North America and actually in the entire developed world. People with macular degeneration don't go completely blind, but they cannot drive, they cannot read, they have trouble recognizing people, and this is a cartoon picture of what a grandmother might see when their grandson's playing soccer. They can't recognize who it is because whatever they're looking at, it's just the image doesn't form in to the brain because the receptors are just not working. There we go. The details are what's lost. I have people who are legally blind and they drive to my office and they drive home and they drive all day and they drive everywhere, but they're not supposed to. But the thing is that sometimes they don't realize that when they're driving a car, they don't have to read. If they know where they're going, they know where the roads are supposed to go. They can see the roads, the trees, the bushes, and they can usually get from one place to another. But it's kind of scary because if something unexpected jumped out in the middle of the road, they might not see it, like a little dog or even a small child or something. So I usually use that to get my patients to wake up and realize they really don't need to be out there driving. Symptoms of macular degeneration are trouble reading because your central vision is what you use to read. Dark adaptation problems, I'm going to come back to that in a second. Facial recognitions, if you're at church and you're trying to see who the preacher's talking to or talking about or just the preacher, you can't see those images very well. Distortion in vision. If you can imagine taking a printed out photograph and kind of just twisting it a little bit here or there, if the retina's got fluid underneath it or it's not working, the image isn't very straight. People say all the time the telephone poles are crooked. Well, what they're saying is when they look at something they know should be straight, like a telephone pole or a fence or the roof of a house, when they look at it, the telephone pole kind of curves like this, or the roof's got a dip in it, and some of those things they don't pick up unless they test each eye individually, because your dominant eye or your good eye will usually take over. Dark adaptation means that, like, if you're in a bright sunny day like outside right now, and you came into this room here, this is kind of the way the lights are dim, people would trip down the steps because their eyes just don't adjust very well. And I don't know, does anybody know anybody who's complained about that? Or, you know, another example would be if you're driving at night and all of a sudden somebody has their flashes their bright lights at you, you're blinded for a while. Well, people with macular degeneration have a much more severe problem with that. Another reason they don't need to be driving, especially at night. We're going to talk about two main categories of macular degeneration, and if nothing else, if you leave here today and thinking that Dr. Baker's just full of hot air, I want you to remember that there are two types of macular degeneration. One is the wet kind, and one is the dry kind. And actually, there are hundreds of types, but those are the two main categories we divide them up into. Can anybody guess what the wet macular degeneration may mean? What does it mean when I say it's wet macular degeneration?
Fluid.
There's fluid. Okay, there's blood or fluid under the retina. Okay, simple. And dry? There's not. I mean, it's pretty simple. These two pictures down here and up here are wet. This actually is dry, but you'll notice there's a bunch of yellow spots in the retina here, and I call those age spots. The technical term is drusen, but what it is, they're collections of debris underneath the retina, deposits that build up with time. Dry macular degeneration, we're going to start with the boring kind first. It's a gradual loss of tissues under the retina that are responsible for feeding the retina. If those tissues die, well, the retina doesn't die, but it stops working, okay? This is the most common form, and it's a slow disease. I mean, I see people who show up when they're 65 years old in my office and they have this disease, and a lot of times they're heartbroken because they found out they've got it. They know they're going to lose vision, but sometimes I can tell them it might take them 25 years to have a significant loss of vision. It may not, but it can. Damage is not reversible. It's permanent. When these layers die, it's not like your body grows them back. And this is something that I'll probably say 3 or 4 times a day. Smoking worsens this disease. Smoking makes it more likely to occur, and it makes it happen at a faster rate. Dry macular degeneration, what do we know about it? We know that certain families are prone to early and more severe macular degeneration. The mechanism for this really wasn't known for a long time. However, there's some scientists in Iowa who probably are going to win the Nobel Prize on some research for aging, and they're eye doctors, because they discovered this factor H gene variation that plays a role in this hereditary connection with macular degeneration. Basically this, 35% of people in this room right now carry a gene for factor H that is a variation of the gene. It's just one nucleotide or one little small fragment of DNA. You may have 1 copy or 2 copies, but if you have both copies of that gene, you have a 7 times more likely chance of getting macular degeneration in your lifetime. I mean, and if you've got 1 copy, it's 2 to 3 times more likely. Now this is the first hard evidence that found the gene for macular degeneration. What factor H is, and this does play a role with aging process and also with a lot of other parts of our body. Factor H is, does anybody know? I mean, you guys may be smarter than I give you credit for. I just, found out about it a few years ago, but factor H is a protein that's in our body that works with the immune system, that basically is a gatekeeper. It tells your immune system, it tags cells in your body, basically saying this is you, this is not something foreign, this is not a bacteria. It keeps your immune system from killing your own cells. And if there's a defect in this regulation of your immune system and how it deals with certain components of inflammation, well, you may start losing more of your good cells at a faster rate. And that's why we think inflammation is an important component in the development of macular degeneration and actually in the entire aging process. So probably, nothing's sure in medicine, but probably some modifications or some research along the factor H genetics are going to determine a lot of things about how we age. And that's going to affect all of you in this room. So just be keeping your ears open about that. Dry macular degeneration, back to this. We know that diets containing leafy green vegetables, fruits, and fish are associated with a lower incidence of vision loss from macular degeneration. And as I said before, smoking is associated with an increased risk of vision loss. Obviously, age is associated with an increased vision loss from macular degeneration. Probably about 1% of people in their 60s have macular degeneration, about 5% of people in their 70s, about 25% of people in their 80s, and about 40 to 50% of people in their 90s have macular degeneration. It increases with age, and if you live long enough, maybe we'll all have macular degeneration. But the risk factors for macular degeneration, again, I'm going to say are age, genetics, diet, nutrition, and smoking. Now, I put diet, nutrition, and smoking in red because as a doctor, we like to focus on the things that we can change. I can't do anything about your age. I can't do anything, well, I guess I could kill you, but that's not really what a doctor is supposed to do. But I can't do anything about your genetics. You were born with them, and you take that with you until we can learn how to change it. That's what you've got. But diet and nutrition is something, your health insurance doesn't have to pay for it. You can do those things yourself. Smoking, that's another thing that you can make a big difference. And these two factors probably can make a 25 to 50% change in your risk for macular degeneration. So if you have a diet that is not very good, not green leafy vegetables, high fats are bad. If you smoke, those are things you might change to make yourself better. And this is just restating that basically. Spinach, collard greens, broccoli, blueberries, cherries, tomatoes, grapes are good. And heart-healthy diets that have fish or omega-3 fatty acids probably are helpful. Low-fat and low-sodium diets are probably not. There was something called the Age-Related Eye Disease Study, and we're actually participating in Paducah in the Age-Related Eye Disease Study 2, but this was a large study that looked at thousands of patients, and they gave them vitamin supplements. They supplemented their antioxidants with vitamin C, vitamin E, beta-carotene, and zinc, and copper. And they found out that if they just gave the patients antioxidants, they reduced their risk of severe vision loss from macular degeneration by 17%. If we gave them zinc, it was 21%. If you mix the two together, 25% less vision loss with macular degeneration. We are looking, as I said, in Paducah, we're doing the AREDS 2 study, which is basically taking this information to the next level. We're looking at more of the trace elements, some other things like lutein, zeaxanthin, and varying the formula a little bit to see if we can up that a little bit more. The bottom line is this: 1.3 million people are at risk for severe vision loss in the next 5 years. These are people who already have macular degeneration. If you took all those people at risk and put them on vitamins, you're probably saving 300,000 people in the United States from going legally blind. Now that's why we talk about these things, and that's why you'll see a lot of vitamins on the shelves. That's a lot of people to save from going blind. Okay, now, anybody have any questions about what we've gone through so far? Because that's the dry part. I see some of this going on. No, actually, I don't see. You guys are doing great so far. Hopefully, I'm keeping you awake. Okay, we're going to go to wet macular degeneration. Okay, wet macular degeneration is, as we said, it's a growth of abnormal blood vessels under the retina. It's actually kind of like a cancer in that you've got extra things growing where you're not supposed to have them. But it doesn't spread, it doesn't kill you like cancer, but it is an abnormal growth. There's fluid that accumulates under the macula. The macula, I'm sorry, I should have told you this earlier. The macula is the center part of the retina. That's why we call it macular degeneration. It is a retina degeneration, but it is the center or the bullseye of the retina that's degenerating. That's why people have trouble seeing to read, because that's what you use your macula for. Wet macular degeneration is a generally rapid loss of central vision, and I tell patients it's usually a factor of days to months when they have this disease. So as you can see, this is a much more severe form of the disease. People who have this disease, who come down with a wet macular degeneration, can go from seeing 20/20 to legally blind in a matter of a couple weeks, okay? And it can be permanent. It is the most treatable form of macular degeneration. Spell check didn't catch that one. And many treatments are available. And what we basically can do with our treatments is try to convert people from the wet kind of macular degeneration back into the dry kind of macular degeneration. Back in the 1980s, we started treating this disease with laser treatments. And this is like the Star Wars laser where you can zap somebody and it actually burns them, okay? We actually have some of those good lasers, not like this little laser pointer right here, but I can cause some tissue burning with the lasers I have in my office. It's kind of neat. But what we did is when people had those blood vessels that were growing under the retina and they were leaking and bleeding, causing people to lose vision, we basically took a hot laser and zapped it, and we cauterized it, burned it, we killed the blood vessels that were bleeding, but we also killed the retina that was on top of it, because remember, these things are under the retina, all right? Now, what did that do? Well, believe it or not, it did have some long-term benefit and visual outcome for people who got this treatment, because we gave them a big blind spot when we shot the laser in there, okay? But by killing those leaky blood vessels, we actually kept their blind spot from being bigger over time because this thing kept growing and growing and growing. Now, patients did not like us when we did it, and we didn't like to do it to patients. I mean, there were several times where people who had this disease could still, they knew they had a problem, but they could still maybe see to read a little bit and to drive. And if you zapped them, you would actually instantly make them worse. Now, we don't like to do those kind of treatments. But as you can imagine, there's a lot of people out there that say, boy, that doctor just blinded me with that laser. And in a way, they're honest. It's true. About the year 2000, actually this started probably in the mid-1990s, one of the neatest things that ever got developed for retina surgery, and I'm telling you, this is neat. We can actually go underneath the retina with little bitty instruments. We put a little fluid in there to kind of lift the retina up, and we take these little fancy tweezers under a microscope and go under the retina and grab those leaky blood vessels and pull them out. And I'm telling you, this is better than any video game you'll ever play because it's just awesome. But only a few people got a visual improvement with this. Now, when we did it, we could make the retina look a whole lot better. But just because you can make it look normal doesn't mean it's going to work normal. And there's just something about the manipulation that kept the retina from working well. So we don't do this very much anymore. There are a few select cases where the anatomy is just perfect for this to work, that I still get a chance to have this kind of fun. But the other treatments that have come along are so much better that we just don't do this very much. Back in the year 2000, 2001, something called photodynamic therapy came around. This is just one of those great things that combines engineering and pharmacology and everything. They basically invented a drug that would somehow have a preference that settles in those bad blood vessels that are under the retina. And the drug itself doesn't kill all your bad blood vessels, but it's activated by a laser or a special wavelength of light. So we give people an IV infusion of the drug. And if you remember that angiogram picture that we showed earlier on, the drug collects the bad blood vessels, then we shine a laser into the eye. And this is not a burning laser. It's, I could shine this laser on you all day long, you wouldn't feel a thing. It's just a special collection of highly tuned wavelengths of light that are specifically designed to cause a chemical reaction in the drug. The light changes the drug, and then once the drug's changed at its location, it kills those blood vessels that it's mostly collected in. So it's a good thought. It is a much more selective laser treatment, and for the first time, this is the first treatment that significantly reduced the severe vision loss from macular degeneration. Now, notice how I say significantly reduced severe vision loss. It actually didn't make people's vision better. And you have to repeat it about every 3 months because it doesn't completely kill the blood vessels. They start to grow again. It's just kind of like a cancer treatment. But this is a graph that showed the difference between the people who got the medicine and got the treatment and who didn't. People who did not get the treatment, this is after months, so this is about 5-year study. their vision dropped 20 letters on average within about 2 years. Now, what happened at 2 years, they found out that the medicine worked so well that they converted everybody who wasn't getting the medicine to getting the medicine, so it doesn't continue to drop off very much. But in actuality, the vision does continue to drop after without treatment. But the difference was the people who got the treatment, the Visudyne medicines, verteporfin, people who got it, they only lost on average about 6 letters. Now, on an eye chart, 20 letters is 4 lines on the eye chart, okay? And 5 letters is 1 line. So the difference between people who got this medicine and got this treatment and didn't for a specific type of wet macular degeneration was 5 letters versus 20 letters, or the difference of losing 1 line on the eye chart or 4 lines. So it did make a difference. The problem with it is this medicine also, the laser costs about $600 to do it. The medicine, each application of medicine is about $2,300, so it's about $3,000 of a treatment every 3 months. So it's a very expensive problem. All right, the next one is 2005 arrives, and we have something, this is the revolutionary treatment that has come about. It really changed my life, changed my patient's life. It's called anti-VEGF treatment, and I'll tell you about what that is in a second. But this is a picture of what it is. Does it look like fun? It's actually pretty fun, but it's fun for me. It's a very significant breakthrough in wet macular degeneration. It's the first treatment to show an improvement in vision in these people with wet macular degeneration. This is that same kind of graph. This is a 2-year graph. At each point over a period of time, even after about 4 months, you'll see that on average, people who got the treatment gained about 5 or 6 letters in vision. And over time, people who did not get the treatment lost about 15 letters. So it's about a 21 letter, 22 letter difference in vision, or about 4 to 5 lines on the eye chart after it's all said and done with. And as I said, this is the first treatment we're being able to give people whose vision got better. Does anybody know why there's a little dot so often along this graph? Anybody guess? Well, they came in every month for 2 years. And the reason they came in every month for 2 years is they got a shot in their eye every month for 2 years. So even though it's an exciting treatment, it has its drawbacks, and we're going to talk about that. So what is VEGF? This is more fun stuff. I can tell you guys are really interested in this. But VEGF is basically a hormone. It's a growth factor. It's in a family. There's a lot of different VEGF growth factors. And it's secreted by a lot of our cells. It's secreted when our cells get damaged. It's secreted when we are low on oxygen. And it's how our body regulates the growth of blood vessels, okay? And our body does some really crazy things with blood vessels. If you break a bone, well, the way the body heals a broken bone is it grows blood vessels in at the side of the broken bone, and those new blood vessels help reorganize the tissue and heal your bone. So the whole process of blood vessel growth and how your body repairs itself is regulated by VEGF, but also that's why one of the things we think that people convert from the dry kind to the wet kind of macular degeneration. As the tissues in your eyes go bad, it's something about the way the body's trying to fix itself by growing in new blood vessels it's like the fixing process has gone astray, because unfortunately in the eye, under the retina, the blood vessels that you were born with are all good. Every extra blood vessel is usually bad. It causes problems. These are the 2 drugs that are right now being used to treat macular degeneration. One's called Lucentis and one's called Avastin. They're both made by the same company, Genentech. Lucentis was developed specifically for the eye, and it costs $2,000 a shot. So if you figure people come in for a shot, they have to pay their insurance, or your tax dollars are going to Medicare, which is paying insurance to pay for Lucentis, $2,000 every time someone comes in for a shot of this. Now, interestingly, the other drug that we use is Avastin, also made by Lucentis. It is a chemotherapy agent for colon cancer. And it was a smart eye doctor who realized that the same way it was working on colon cancer, it was inhibiting the VEGF that made the blood vessels that supplied blood to the colon tumors. It made those blood vessels wither away so the tumors shrank. Well, that same hormone was what was making the blood vessels grow in the eye. And so you give people these medicines, and those blood vessels shrink away without laser, without surgery, or anything. They stop leaking. But anyway, so we use either a drug that's made for the eye or a small fraction of a dose of a chemotherapy agent. The reason this is used a lot by eye doctors is that we can get our hands on it, and we can take 1/300th of the dose that was being given to the people for colon cancer, and it costs about $50. So probably in my office we use about 2 shots of this for every 1 shot of that for a lot of reasons, and it seems to work just as well. So this is just a picture of someone getting a shot in their eye. I'll go ahead and anybody want to see the process? It's kind of fun. This is a little bit blurry. The next pictures will be better. But basically, I will numb the eye where I give the shot. What I just did is put just a numbing drop on the eye. Now I'm going to go back right where I'm going to give the shot. We have audio too. So I'm numbing the skin right over the eye where I'm going to be giving the shot. I don't want the patient to jump when I give the injection into the eye. So the next thing we'll do is I'll clean off the eye with an antiseptic, because I do not want to get any germs into the eye where I'm going to give the shot. So we'll clean around the eye. We'll put some antiseptic in the eye. And then we go ahead and put a little device in there to hold the eyelid out of the way so the patient can't blink right where I'm giving the shot. And I have him look down to the right, so he's looking away. I measure it with a little device, because there's a certain area I have to be in that I won't hit anything critical with a needle. And here I go. Now it's kind of hidden behind my knuckle there. We just go right in. And we hold a Q-tip over it when I'm done, just to keep the fluid from coming back out. Believe it or not, the patient didn't feel that at all. So, and anybody want to try that? Now, actually, this is the problem that this has. We used to have a disease where people would come to us, and I'd look at them and I'd say, hey, you've got macular degeneration. You're legally blind, or you're going to go legally blind soon. I can laser you, and it might make it a little bit better, or I can do surgery, and it's a big ordeal, and you might have a small chance of improvement. But most of those people, I could just diagnose them and tell them to get magnifying glasses, and it couldn't really do much to help them, with changing the course of their disease. Now we've got a drug that we can actually make a big difference in their function. And anybody who's had vision problems know that when your eyes start to go, your whole life changes. So think about when you're 75 or 80 years old, and you may not be able to hit that tennis ball or the golf ball like you'd like to do it. You still like to be able to see your grandkids. And so some of the last abilities you have when you're older is your senses, like sight. So something threatens that, really does cause a severe problem in your life. What I'm having a problem with now is I have to give these injections over and over again, because once the medicine goes, the disease often comes back. Now, I'll tell you about some things that we're trying to change about that. But 1/3 of my patients have macular degeneration. And so I was pretty busy to begin with. Now I've got a disease that they have to come back every month or every 6 weeks for a shot. And they do, because it makes them better. So we're starting to have like STD clinics, but we're giving injections of eyeballs now. So finally, the treatment of tomorrow for macular degeneration. We are participating in several clinical trials. How many? 16 clinical trials in Paducah, where we're trying new medicines for diabetes, and macular degeneration is one of the big areas we're exploring. We're looking at combinations of lasers, whether it's the Visudyne or the thermal lasers, along with the anti-VEGF injections, to reduce the number of injections. And this is actually, this is showing some promise. We're looking at new anti-VEGF medicines. There's one called VEGF Trap. It's just a pharmacy drug name, but that VEGF Trap may last up to twice as long as our current medicines. So if you had to come in for 12 injections a year, wouldn't it be nice to come in for 6? It would. And it may last up to 4 months, so it would, if you could do it every 3 months, it would be great. We're looking at combination therapy with steroid implants, so you can hit home runs and see the ball at the same time. No, steroid implants here, when it goes into your eye, it can also inhibit VEGF in a different manner. And we do have some steroid implants that may last up to 1.5 years. So if that works to prevent them from coming back for injections, it's very good. And finally, the last thing is pretty exciting. We're going to be doing this here in Paducah very shortly. We're going to be conducting some clinical trials where we're giving the Lucentis or the anti-VEGF injections, but we're taking a little probe that's got some radiation at the tip, and we're going to be holding it over the macula in the operating room, and that radiation exposure for just a few minutes, it may be enough to keep those blood vessels from coming back for good. And the initial clinical trial data for that is very, very promising. So, and that's just some of the things we're doing here in Paducah. Now, I've lost my voice, so if anybody wants to ask some questions, I'll try my best to answer them. Thank you. Thank you. Any questions? Yes.
What exactly determines if someone is legally blind?
Good question. Specifically, worse than 2200 vision with the best pair of glasses that can be made for that person. Okay? In other words, glasses will only get you up to that level. So, and that's in both eyes. So now what determines whether you can drive or not? Usually 20/40 vision in at least one eye or better is driving vision. So there's actually a big gap between people who are legally blind and those that can just not drive. Does that make sense? And there are other definitions of legal blindness, like some retinal diseases take away your peripheral vision. If you have tunnel vision, if you have a visual field that's less than a certain amount, that's also a definition of legal blindness.
I was just going to ask, the medicine that you're given in the injection, like whenever you find out that they have that, how long, is it like a forever thing, or, and you might have said that, I didn't.
No, I didn't. She asked people who have to get these injections, do they have to get them every month or every 6 weeks forever? Is that what you really mean? Hopefully not, okay? We know that some people can get one injection and it never comes back, okay? We always are looking for ways not to have to keep injecting them, but every individual is different and their macular degeneration is different. What we usually do is we'll give somebody 3 or 4 injections about a month or 6 weeks apart at first. And then we start spacing the times that they come back to see us if their disease is cleared up by that time. If it's not cleared up and we think it's going to work, we keep going. If it's cleared up, then we might give them 2 months or 3 months and see how they do. And if they don't show any signs of it coming back, we may not keep giving them the drug. So yes, we don't give it just.
Is there not too much that you can give? Is there a point where you can stop?
We haven't found it yet. In the initial trials, people got 24 injections in 2 years. Now, I'm not a patient in my practice who's gotten anywhere close to 24 injections yet.
What's the side effect?
Great question. He asked what the side effect of the medicine is. None. Well, I'll say that as a doctor, considering everything, we haven't seen any significant problems at all with it. There is a theoretical risk because this VEGF medicine, the VEGF hormone that we're inhibiting, it doesn't stay long in your body. Your body's always making it, so there's always like a little bit of it wherever you need it. When it is given as an IV medicine for chemotherapy, there is up to a 5 or 6% risk of a heart attack or stroke when you get it. So that is a very significant risk. Since we give with the Avastin, we're giving 1/300th or 1/400th of that dose, and we're giving it directly into the eye, not into the bloodstream, we have not seen that be any risk at all. But they're looking at thousands of people. In fact, just a couple months ago, they published some data that suggests that they looked at a 0.3 milligram dose of the Lucentis and a 0.5 milligram dose, and there was not a difference in, well, at first they thought there might be a little bit higher chance of a stroke, like a 1 in 250 chance versus a 1 in 400 chance. But there has not been a significant statistical difference in that population. But we still look at that because of that theoretical possibility. But overall, that minor risk and the minor risk of infection that you get when you get a shot, it doesn't slow us down or the patients from getting it. Those are great questions. Yes, ma'am.
Is there candidates that are not, people are saying that are not good candidates for it, and if they're not, what is your criteria?
Yes, there are definitely. She asked, are there people who this treatment is not for, or are there people who it is for? Well, first of all, cell phones aren't supposed to be in here, are they? Anyway, I'm sorry about that. I'm not on call. All right. People who come to me, 2 out of 3 of them have dry macular degeneration, or at least used to be that way. Okay, so dry macular degeneration patients, this medicine is not for those people. Okay? People who have had wet macular degeneration for a long time, a couple years, 3 years, and have not had any of this treatment may not be a good candidate for it because their disease may have already been so bad, their damage is already there, it's already permanent. So we can give them shots all day long and they won't get any better. So and right now, those are the 2 most common reasons that people come to me that I don't give them the treatment because it won't work. All right? So it's for wet macular degeneration and usually fairly recent onset wet macular degeneration.
When you go to the eye doctor and they dilate the pupil, is this what they're looking for?
One of the things that she asked if you go to an eye doctor, if they dilate your pupil, is this what they're looking for? Definitely, if you're over the age of 45 or something like this. This disease doesn't occur in, you can have other retinal diseases that you're looking for at that time. Diabetes, the most common, but there are several others. This is a disease that, if you have a family history of it, I think it's very wise to get a yearly dilated examination after you get probably 45 or 50 years old when it has a possibility of showing up. Because if you start to show signs of it in your eyes, like little age spots like we talked about, those are the people that benefit the most from vitamins. If you just have a family history of it, like most of us probably here do, you get a benefit of taking vitamins unless you're starting to show signs of it in your eyes. So.
How do you make the decision between choosing one drug versus the other? 50 plus 1 versus...
That's my job. That's great. That's what we have to do all the time in medicine. He asked, how do you know how to use one drug versus the other? Well, in this particular dilemma between these 2 drugs, I have to say it's more economic than it is actually efficacious. In my practice, we had the ability to give people the Avastin for about 9 months before Lucentis was approved and wasn't even available. At that time, insurance didn't pay for either one of the drugs, and people could pay $50 out of their pocket, but they couldn't pay $2,000 for the repeated treatments. I mean, I wouldn't. And so we used it, and we got some great results with the Lucentis, with the Avastin, which was the $50 one. And then when Lucentis became available, well, we had this new drug, it's FDA approved. Why don't we start using that more often? So we switched a lot of our patients and started using Lucentis first. Well, then in my practice, I noticed that the people who got Lucentis and the people who got Avastin, there wasn't a big difference in how they did. So the $50 drug, in my opinion, does just as well as the $2,000 drug. So I would prefer to use the $50 drug for a lot of reasons. Now, if a patient has a preference for the $2,000 drug, for the Lucentis, that we usually honor that. We usually give it to, but even if you have insurance that pays for things, I'm sure all of you who are paying your medical bills realize that you usually have some kind of copayment or there's some percentage that your insurance isn't paying. So even if Medicare pays 80% of it, then you still may have to pay $400 for that drug. And if you're lucky or have a supplement, well, then you may not have to pay as much, but it still ends up, there's an out-of-pocket cost that's different. What else do we know about the two drugs comparatively? There's never been a study that compared the two until now. There's a clinical trial that's being started that is comparing Lucentis to Avastin, but it is not being paid for by the drug company. You figure out why the drug company wouldn't pay for it, because they have an FDA-approved drug that's the only FDA-approved drug, and it's $2,000. Why would they want their $50 drug to be just as approved? It doesn't make sense. But the federal government actually, and Medicare, are actually helping pay for that trial, first time ever for a trial. But in this case, dollars make a big difference. Thank you all. Oh, yes?
What does the future of macular degeneration and treatment look like? Are they working on new stuff?
Excellent. Yeah. Yes, definitely. Like I said, we've got several clinical trials where we're actually starting here in we didn't start the trials, but we're participating in the trials in Paducah. They have new drugs that may last longer. They have combinations with lasers and radiation that look like they may be helpful. And the neat thing about this is the biggest hurdle for the delivery of new medications to the eye was that shot. 10 years ago, eye doctors were very scared to be sticking needles in the eyes. I mean, we're still scared, but we know now we can do it, and the patient's generally comfortable. They wouldn't be coming back every month if it hurt them. It's like going to a dentist that would hurt you. It doesn't happen. So we've got a safer way and a comfortable way to give people drugs directly into their eye, and it has opened up the door for a wide range of new drugs. So my field is getting very exciting, very exciting. I will guarantee you that within 5 years, we'll have more and better treatments for this disease.
Drug company or producer trying to come up with like the antioxidant magic pill that reduce, like you said, by 25% the zinc and the other things?
Yes.
Have they come up with a vaccine yet that specifically targets that?
Yes. She asked, is there a specific vitamin that's been developed that is meant for macular degeneration patients? And the answer is yes. It's the AREDS formula that we put up there that has so much vitamin C, so much vitamin A, so much vitamin E, and zinc. And that is like when you used to buy toothpaste that was recommended by your ADA. Well, now if you have macular degeneration, I recommend my patients go get a vitamin that has the AREDS formula in it. And there's 3 or 4 companies out there that make those vitamins right now. And they're a component in a lot of different vitamins. Now, the thing is, you got to be careful. You can take too many vitamins. Vitamins in these high doses can be toxic, so you need to be careful. I have a lot of patients that are older and they want to do everything they can to not lose vision, and they're taking 4 different types of vitamins. And to be honest with you, they're probably getting ready to kill their liver or their kidneys by taking too much in the way of vitamins. So I usually recommend paying attention to not taking too much as well. Thanks a lot for listening, guys.